Okay, hello again, class. It's nice to see you, so to speak. Today we're going to be talking about depressive disorders and bipolar disorders. And I frequently see clients throughout the week that have depression and or bipolar disorder. And in your practice, I'm sure you will as well. All right, so I want to first start out by saying that the information that I'm about to present in these slides that I'm looking at has been taken from the DSM-5 unless otherwise specified, and with the exception, of course, of information about treatment modalities. Okay, so I want to begin by talking about manic episodes, and then we'll talk about hypomanic episodes and depressive episodes. These types of episodes are important to understand because they're useful in making diagnosis of bipolar disorder. All right, so for a manic episode, there's a distinct and abnormal period which lasts for at least a week of euphoric, expansive, or irritable mood. And this abnormal period, it also represents a change from previous functioning. Now, it can include reckless behavior, such as overspending, reckless decisions about sex, and general risk-taking. Now, for instance, I've seen plenty of people that that were manic that would way overspend. They'd run their credit cards up and all of that. In fact, I remember one person that I knew went to buy a used car, and he came back and he was manic, and he came back with 2 used cars. He got the guy from the car lot to drive a car home. Well, you know, of course the guy from the car lot will drive a car home if he can sell the car, you know. So this guy came home with 2 cars, and because he was manic. I've had people that would engage in sexual activity with multiple people in a very short period of time. I've had people that would take risks in general. I remember this one fellow that would go to cook. He was one time went to cook some, I think it was spaghetti he was making. He was manic. The next thing anybody knew, he had pork chops that were frying, he had spaghetti that was going, he had a roast in the oven, and he was baking a cake. You know, he was cooking everything in the kitchen. He was manic. And feeling really expansive and euphoric, and had lots of energy, and was just having a good time. A lot of times people that have a manic episode will experience sleep disturbance. They won't sleep very much, or if they do, it's for very short periods of time, and they can be basically up for several days, with the exception of maybe just a little cat nap here and there. They have increased productivity. I've heard people that were manic say, hey, you know, I cleaned my house and I fixed my car. Maybe they had written a term paper and had just done all kind of various and sundry things, and that they felt really good. And in fact, I've had clients with bipolar disorder tell me that they like being manic. At least some of them like being manic because it does increase their productivity. Now, I want to tell you a little about hypomanic episodes, and they're similar to the manic episodes, but the duration can be as little as 4 consecutive days. So, with the manic episode, we're looking for a week or more. With the hypomanic episode, we're looking for as little as 4 consecutive days, okay? Now, for depressive episodes, symptoms need to be present for at least 2 weeks, representing change from previous functioning. And the person will report feelings of depression, decreased personal value. In other words, their self-esteem will be pretty low. And that'll be present for most days of a 2-week period. And they'll also experience or report anhedonia, fatigue, poor concentration, weight change, and thoughts of death, and some other things that you'll find in the DSM. And by the way, in our work together, you may hear me make reference to words that are new for you. What I encourage you to do is look those up. I want you to get in the habit of being able to say, oh, well, what's anhedonia mean? And then be able to look it up and find the answer to that, as opposed to me just giving it to you. Okay, so let's talk a little about bipolar 1 disorder. Now, you may or may not know that bipolar disorder is also referred to as manic depressive disorder. You may hear it used in that context. And what you probably don't know is that there are a couple of different types of bipolar disorder. We're going to focus on bipolar 1 and bipolar 2 disorders. So for bipolar 1 disorder, there's the presence of manic episodes. Major depressive episodes are common, but not required for this diagnosis. So for bipolar 1 disorder, a person doesn't actually have to be depressed at times. All that's required is a manic episode, all that's required are the manic episodes. But again, oftentimes people do have the depressive episodes. There's a continuum of severity from mild to severe, all the way up to severe with psychotic features, and then back to full remission of symptoms. We know that genetics play a part in bipolar disorder. I don't know that I've ever seen a person that had bipolar disorder where we couldn't trace it back to a parent or a grandparent or an aunt or an uncle. We know that people with bipolar disorder have higher divorce rates. And if we think about that, it kind of makes sense, because sometimes people with bipolar disorder can be explosive and very emotionally labile if they're manic and are agitated. Because as I mentioned earlier, sometimes people that have mania aren't always happy-go-lucky. Sometimes they are agitated. And so it would make sense that the divorce rates are a wee bit higher. In fact, I know one person that had bipolar disorder, and he had a lot of trouble maintaining interpersonal relationships. He would usually end up in some kind of argument or disagreement with them. And it affected his ability to work and affected him at home as well. So again, bipolar 1 disorder anyway, is definitely on a continuum. I have seen people with bipolar 1 disorder who were able to get medication and treatment and psychotherapy and all that, and that they did quite well and lived a pretty normal life. And on the other hand, I've seen people with bipolar disorder that was so severe that they had to frequently be hospitalized, wasn't able to function appropriately in their lives, and that medication didn't appear to do a whole lot for, nor did therapy. So, and then I've seen everything in between. So, from my experience, what I've noticed though is that at least most of the time, medication and psychotherapy can be beneficial and help people with bipolar disorder live an improved life. And indeed, the difference can be dramatic. You know, when a person is unmedicated if they have bipolar disorder versus being on medication. And of course, therapy makes a big difference too in conjunction with the medication. The average age of onset for bipolar 1 disorder is 18 years, but it can occur at any point in the lifespan. For people with bipolar 1 disorder, there's an increased suicide risk. And of course, I've already mentioned the functional consequences. People with bipolar 1 disorder sometimes are unable to maintain employment, maintain relationships, and that kind of thing. Bipolar 1 disorder too, of course, a person with that disorder tends to impact the whole family. You know, being social workers, we think of a systems perspective, and oftentimes if a person has bipolar disorder, it does indeed impact the whole family. As a matter of fact, I can't think of one case where it didn't impact the whole family. Comorbidity is common. Frequently, people that have bipolar 1 disorder will also self-medicate with marijuana or alcohol or perhaps some other illicit drug. So it's not uncommon at all to see that. And sometimes we see people with bipolar 1 disorder that has other psychiatric disorders. So be sure to refer to your DSM for a differential diagnosis. Okay. With bipolar 2 disorder, we see hypomania that lasts at least 4 days. Then we see a major depressive episode that lasts for at least 2 weeks with a change in previous functioning. There's no full manic episode. There is a functional disturbance, so the person's ability to function is impaired. And average onset is in the mid-20s. And again, I refer you to the DSM for a differential diagnosis. And so basically when I think of bipolar 2 disorder, I think of what? Well, the distinguishing feature is the major depressive episode, right? Whereas in bipolar 1, there has to be mania, or at least hypomania, and there can be an absence of the depressive episode, whereas in bipolar 2 disorder, the depressive episode is a requirement, as is the hypomania that lasts for at least 4 days. So when I think of bipolar 2, I think of a person and usually when I see somebody with bipolar 2 disorder, which is a whole lot less often than somebody with bipolar 1 disorder, by the way, but when I see somebody with bipolar 2 disorder, the first thing that pops into my head is depressive symptoms and then hypomania. All right. You'll also notice in the DSM that there's something called unspecified bipolar and related disorder. And so what that is it's used, that diagnosis is used for when symptoms are present, but full criteria isn't met. Or it may be that there's insufficient information to make a diagnosis. And so then we say that the person has unspecified bipolar and related disorder. And it's appropriate as you learn more about that person, if you get information that supports a full diagnosis of bipolar disorder, it's appropriate then to make that disorder. Okay, earlier I said something about clients with bipolar disorder and people with bipolar disorder self-medicating. Many of my clients with bipolar disorder self-medicate and have substance abuse problems superimposed on and secondary to bipolar disorder. Many of my clients at some point in their treatment begin to feel emotionally and behaviorally stable and stop their psychoactive medication, and then they relapse. So that's not uncommon too. So if you're working with someone with bipolar disorder, be aware that it's certainly not uncommon that the person will begin to feel pretty good and decide they don't need their meds. Maybe they don't like the side effects and all of that, and they stop taking the medication, and then in a couple of weeks' time, they're in trouble again, and quite frequently calling out for emergency care. And that tends to happen with people that are newly diagnosed and newly treated with bipolar disorder. Most of my clients that have been aware of their bipolar disorder for several years have realized that, well, no, it's not a trial and error thing, and yes, I have to take my medicine, and if I don't, I'm going to become either really manic or really depressed, and it's going to disrupt my ability to function. And so they get that and tend to stay on the medicine better than people that are newly diagnosed and that have just beginning to receive treatment over the last year or so. Okay, so let's talk about treatment for bipolar disorder. The most important thing treatment-wise for bipolar disorder is psychoactive medication. We know that bipolar disorder is a genetic type disorder. It's an organic type disorder. You can't do therapy and resolve the issue. Therapy alone, it won't work. The best way to treat bipolar disorder is with medication. And in fact, I would argue that any treatment of bipolar disorder that doesn't include medication is unethical. And that's my opinion. Feel free to make it yours. So psychoactive medication is the number one intervention for bipolar disorders. Now, studies have also shown that psychotherapy helps in conjunction with psychoactive medication. And that's true for a lot of the disorders. A lot of the disorders are best treated by a combination of medication and psychotherapy. Now, it's not true for all of them, but for a lot of them, that's true. In terms of psychotherapy, what we try to do with someone with bipolar disorder is a couple of things. One thing is I address functional issues, such as interpersonal skills. It may be that somebody's had bipolar disorder and they haven't learned to develop appropriate interpersonal skills. And it could be that they get treatment, they get medicine, and they get psychotherapy, and they become regulated. And then they look around and they say, oh, well, I no longer have these debilitating manic episodes and debilitating depressive episodes. But you know what? I just don't know how to get along with people because I've never done it. I haven't developed those skills. So sometimes that's what we'll work on. We'll also work on loss and grief issues. It could be that the person with bipolar disorder that was untreated had a divorce, because they weren't able to engage appropriately in interpersonal relationships. Could be that they're lonely. Again, they haven't done interpersonal relationships. Of course they're going to be lonely. They don't have any friends. Don't know how to make friends. Don't know how to maintain friendships. Could be that they've messed their career up and they have to address feelings about that and process that and maybe start in a new direction with careers. Sometimes I've had clients that didn't know what normal was, whatever we decided to call normal. And they've had trouble regulating themselves because they don't really quite grasp the concept of normal because they've never really been normal. And then, of course, psychoeducation for the client and family is important in psychotherapy. A big part of what I do treatment-wise with people that have bipolar disorder is help educate the family. I'm thinking of one case where a gal had bipolar 1 disorder, and her husband would get mad at her because when she would get in the depressive phase, she would sleep for days on end. She'd get up and go to the bathroom and that kind of thing, but she wasn't productive and didn't feel her role in her family, the role that she had taken on and all of that as a wife and a mother. And the husband would get mad and said, oh, well, she's just lazy. She's on the couch when I leave to go to work. She's on the couch when I get home, stays on the couch all evening. She won't interact with the kids. She won't interact with me. Doesn't do anything that she needs to be doing, and the house is a mess. And they had one of these traditional families where the guy went to work and the woman was expected to clean and cook and all that jazz, which is fine if that's what they choose to do. But she wasn't able to operate normally in her role that she had assigned to herself and that the family had become accustomed to her doing. And so part of my job was to help him understand that no, your wife isn't lazy, and no, she's not mad, and no, she's not willfully doing these things, but yes, she does have a mental illness, and yes, indeed, she can't help that she's feeling and doing the things that she's doing right now. And so a little bit of education for him and for them went a long way. It helped him to understand what was going on with her, which meant that he wasn't willing to, didn't feel the need to attack her verbally, and they didn't argue that way and all that. So now another thing is, in psychotherapy, you want to provide emotional support to your client. And then there are little peripheral issues sometimes that pop up, maybe running some kind of interference for the person at work. I've had a person that I had to send letters to his work so that he could maintain employment and all that, or that would allow him to go back to work and those kind of things. Okay, so now I want to talk about major depressive disorder. You'll see a lot of people with major depressive disorder if you go into clinical practice. The duration of symptoms is at least 2 weeks long, with a change in previous level of functioning. People with major depressive disorder report feeling depressed most of the day, nearly every day. They have anhedonia, which is another word that you may want to look up. They have weight change, sleep disturbance, fatigue, thoughts of death, low self-esteem, problem concentrating, and a general disruption in their ability to function. Now, we want to make sure before we diagnose major depressive disorder that the person's symptoms isn't attributable to substance abuse. Okay, so we need to rule out substance abuse before we decide the person has major depressive disorder. And about major depressive disorder, we know that it's more prevalent in females than males. And statistically, the highest age group with reported MDD is the group spanning between 18 and 29 years. Interestingly, it's my experience, my clinical experience, that this is the age group that's less likely to seek psychotherapy and less likely to complete psychotherapy when they start it. That would be the group from 18 to 29 years of age. And so what that says to me then is there are a lot of people out there walking around with major depressive disorder that's suffering and that's doing so unnecessarily. Environmental, genetic, and comorbidity factors can all serve as risk and prognostic indicators. And when you're thinking about major depressive disorder and diagnosing that, you want to think in terms of, is this a single occurrence or is it something that recurs every so often? And in fact, when you do the diagnosis, that would be something you would want to be indicative of, is whether or not it's a single or a recurrent issue. Now here's just some information that I thought would be useful. When I think of depression, I think of genetic versus episodic depression. And what that means for me is that a genetic depression is something that that is going to be there regardless of external events and factors. Genetic depression usually is something that a person struggles with throughout their life and a lot of times requires medication. Now, let's contrast that with episodic depression, which is basically an episode of depression that is episodic depression oftentimes happens because of external events, maybe a divorce, maybe the loss of a loved one, car accident, loss of a job, midlife crisis kind of deal. Could be any of those things. But basically, it's just things that happen in the environment. Episodic depression doesn't always require medication, and in fact, unless the person's severely depressed, I like to help them work through the issue without medication at all. If we can identify exactly what kind of antagonist is at work to contribute to the depression. And what tends to happen with episodic depression like that is that that isn't genetically based, is that it tends to be there for a while and then eventually gets better and goes away. Especially if they get help, the person gets help in psychotherapy, because that can serve a couple of functions, including helping the person get better quickly and then helping the person have tools so that they don't have a second episode later on in life of depression. And if they do, perhaps it won't be as severe if they have the tools to work through. All right. I also want you to know about the coding for major depressive disorder. We code for severity. And for instance, the code for major depressive disorder is 296.2, but then there is a fifth digit, and that fifth digit's variable. Now, if the person is mildly depressed, we assign a 1, and so that the code would be 296.21. And then if it's a moderate depression, we assign a 2, and a severe is a 3. So for instance, a severe case of major depressive disorder would be 296.23. And then for unspecified, it would be 296.20, which would mean that we haven't specified or for whatever reason been able to determine if the depression is mild, moderate, or severe. Okay. In my private practice, and then in my practice over in the Department of Psychiatry over at the VA campus, common reasons that clients present with major depressive disorder include loss of sense of purpose and meaning. This is common with retirement and disability. I can't tell you how many people I've had come in that were clinically depressed and had major depressive disorder because they had retired or were disabled. And if you think about it, it makes sense, because in our society, part of how we're defined depends on what we do. For instance, have you ever noticed that if you meet somebody for the first time, usually within 5 minutes of that conversation, they ask you what you do for a living? And in our society, that gives you worth and value, which I don't necessarily agree with. I think that's a bit pretentious and somewhat silly in some ways. So if you think about it, somebody that's retired or disabled, they lose that sense of self, of purpose. And so they're sitting around looking at the walls oftentimes thinking, well, okay, now what? What am I supposed to do? What's my purpose? What brings meaning to my life? And they get depressed because they don't have good answers for that. Another reason that people lose purpose and meaning would be the empty nest syndrome. This happens a lot with the women. I've had women come in that were depressed and they couldn't really put their finger on why. And after we get in there and dig around a little bit, it turns out that they're suffering from empty nest syndrome. their kids have grown up and moved away to college or moved away to wherever and started their own lives, and there's an emptiness there, a lack of purpose and meaning for that parent. And so it's part of my job to help them reinvent themselves and have things and things to engage in and a new direction. And job satisfaction is another example of loss of a sense of purpose and meaning that can take a pretty heavy toll on a person. Other common reasons people present in my office with major depressive disorder include loss of relationship. Because if you think about it, human beings are social creatures for the most part. Now, there are exceptions. Somebody maybe with autism or one of the other disorders that would prevent enjoyment of relationships. We'll get into some of those later. But loss of relationship is a big one in terms of depression. I've had people that come in that were upset because they've had a divorce or they've lost a girlfriend or a boyfriend, and they're all twisted sideways and out of shape about that. Have had people come in that have experienced death of loved ones. I can tell you, as a person that's been a clinician for a long time, the very most difficult situation to deal with is the person that comes in that says, I've been married for 30 years or 40 years or 50 years and my spouse just died. There is no fixing that. There is no fixing that. And the person that's left will always have a huge hole in their heart. And so at that point, my job is to listen and help them process, to provide psychoeducation about the grieving process, to help them understand that they need to be kind and gentle to themselves, and if they feel like crying, then to cry. To understand that there will be periods of time when they feel very sad out of the blue because of that. To help them know that they shouldn't let other people tell them how to feel. And in fact, they shouldn't tell themselves how to feel. They should just feel and let themselves process the grief. I can't tell you how many times I've had people come in and say, well, so-and-so said I should feel better by now. I should be getting better. And I say, well, how do you know? Have you ever been through this before? How do they know what you should feel? Are they inside of you and know how you feel? No, of course not. These people mean well, but they don't know what they're talking about. So please, I'll tell my clients, please don't let them tell you how you should be feeling. Just feel how you feel and go with it. And so it's about psychoeducation. It's about me helping them understand that there will be fits and starts, that there will be times when they feel a bit better and kind of okay, and then there will be times right after that they don't, and it'll be up and down like that for a while. And then eventually, over time, what we do is help that person to develop a new identity, a more functional identity, and to be able to get through the day, put one foot in front of the other. At first, that's what we focus on, and then it's, after that, a matter of building meaningful things and so that they can go on and live life. So the death of a loved one, especially somebody that's a spouse that's been together for a long time, and perhaps even more traumatic is the death of a child. If somebody comes in and is the parent of a child that's died. It's probably the most difficult thing that I deal with in my practice. All right, moving on. I want to talk to you just a minute or two about dysthymia. It's also known as persistent depressive disorder. Dysthymia is a chronic depression that lasts for at least 2 years, and there has not been an absence of symptoms for more than 2 consecutive months. And so this is I liken this to like a low-grade fever. It's not real high. It's always kind of there. It's always a problem, that kind of thing. There's no mania or hypomania with this disorder. There is a high risk of comorbidity, especially with anxiety disorders and substance abuse disorders, or substance use disorders, I should say. And so you want to look at the differential diagnosis pretty carefully. All right, so let's talk about treatment for depressive disorders. Psychotherapy is my treatment of choice, at least most of the time. Cognitive behavioral therapy for people that are able to embrace cognitive behavioral therapy tends to work pretty well, where we explore and arrest erroneous assumptions and beliefs and replace those with more accurate thoughts and beliefs. The problem with cognitive behavioral therapy is that not everybody is able to embrace that, because you do have to have a certain amount of intellect and all that to grasp some of those concepts. I also like existential psychotherapy because it helps to reestablish a sense of meaning and purpose in one's life. It addresses the concept of thrownness, in that we are all thrown into this world, like it or not. We don't have a treatment manual, an operations manual. We're thrown into the world. And it's up to us to accept responsibility for the freedom that we've got. Along with freedom comes responsibility. It's up to us to establish and pursue a sense of meaning and purpose. And existential psychotherapy also questions and corrects the belief that life is supposed to be perpetually good. And it says that sometimes difficulty is part of the experience of being human, which is absolutely correct, and that we need to accept a balance of good and bad. Now, here in America, we're taught that things need to be good all the time, and if it's not, we need to do something about it. And, there's a pill for this if you feel bad, or a pill for that, or, things are supposed to be good, and all that. And I don't think that's very accurate. I think that contributes to depression sometimes, because the reality is that life is hard. Life can be hard, and I think that we need to accept that, well, you know what, life doesn't have to be roses all the time. It's okay if life is not great all the time. And in fact, we can expect some troubles, and that's just part of existence. And I think Europeans tend to have more of a realistic view like that than we do here in America. Now, the other treatment for depressive disorders that I find useful for some of my people, some of my clients, is psychoactive medication. There are some people that have a depressive disorder that needs a little help in terms of medication, in order to work through some of the things in psychotherapy that they need to work through. Sometimes a person can take the psychoactive medication for a while, and it reboots the neurochemistry in the brain and that kind of thing, and it's very helpful. A lot of times, like I said before, a combination of psychotherapy and psychoactive medication is extremely helpful and the best route. Now, on small occasion, there are people who are extremely resistant to treatment in terms of their depression, and they end up having electroconvulsive shock therapy. And you may have heard about that, jokes about it or something. And back in the old days, it was quite brutal. Now it's a whole lot more humane, and is actually quite beneficial for some people that won't respond to other types of intervention. And there's another type of therapy that's not therapy, but another type of intervention that's coming out, and the name of it escapes me at the moment, but it has to do with electromagnetic fields that stimulate the brain. And there's some pretty good research and evidence showing that it's quite useful. In fact, we have a practitioner or two that's using that technique over in the Department of Psychiatry on the VA campus. And then finally, I have on the end of this slide a reference page for the DSM-5. All right, well, I've enjoyed talking with you, well, I guess to you in this context, and look forward to moving on to the next section soon. Thank you.